Hi, everyone. I'm Lourdes, owner and founder of the National Clinical Mental Health Counseling Exam, Bible Prep, and Social Catharsis. On the mental health counseling exam, we're going to discuss treatment planning. Treatment planning takes up 15% of the test items. But the good news is, this is often one of the easiest areas to score well in because it's all about using your counseling knowledge and your skills to build a strong client centered plan. So, in this section of the test and within these slides, we're going to discuss how to collaborate with the clients to create goals and objectives, how to set short term and long term goals that match their diagnosis, identify barriers that may interfere with their progress, recognize client strengths, and help them achieve their goals, and to refer to different levels of care based on their needs and their diagnosis, how to coordinate with other providers for additional or concurrent treatment, and how to guide the treatment planning process ethically, and how to ethically discuss termination and follow up, how to address transitions such as group changes in membership and maintain their continuum of care, and to use the assessments to support their decision making and reviewing the plan regularly. So, this is important because in this session, we're going to learn about ways that we can educate the client about the importance of staying committed to their treatment plan to reach their goals. Mastering this session shows you how to guide real world treatment while staying ethical, collaborative, and goal focused. So, let's get started. So, the benefits of treatment planning is that clients are able to gain clarity about their journey, their experience, and they take ownership in their healing process. Therefore, when that happens, the counselors also benefit. So, in that aspect, we use treatment planning to guide ethical decision making and to ensure that the plan that you make with your client align with their goals and how we're going to continue their care even after termination. So, the plan is to communicate between providers, yourself, and the client to ensure accountability and how you deliver services. So it's basically an overall monitoring on how to be effective in their care. Now, the fundamentals of treatment planning is you have to gather their history, their symptoms, and any previous treatment experiences, and you have to relate it to their diagnosis, a DSM-5 criteria diagnosis. And you have to integrate, based on your progress notes, the objectives within the treatment plan and how you're going to use assessments to establish clear observable markers of progress. So when you think about it, short-term and long-term goals help the client help the clients to feel progress quickly, and the long-term benefit is the bigger changes that they can make. Both should match the client's diagnosis, both short-term and long-term goals. And then in relation to that, you have to identify their barriers. Pay attention to what makes it hard for the client to reach their goals. Like, is it their family? Are they stressing about money, issues, health problems? Do they want to self harm or harm others? So, that is an important component of a treatment plan. Another thing we want to assess is their strength. What is the client good at? What helps them keep going? These are important to use in the treatment plan. And then you have to assess what modality that meets their current needs. Some clients may need outpatient care, some may need inpatient or residential. Don't be afraid to refer the client for other treatment from doctors or psychiatrists or support groups when it's necessary, because sometimes clients need help from more than one provider. And to guide the treatment plan, which is also very fundamental, you have to show your clients the steps that they'll take and what's to come next. Clear planning helps reduce anxiety. And these are essential when planning for a specific client based on their specific diagnosis and their specific needs. Now, your role as the mental health professional is to facilitate. You direct the treatment planning, you offer the knowledge, but you have to honor their autonomy. So, if you're dealing with someone with trauma, we don't force them to relive that experience. We allow them to take the time to share and disclose what it is that they feel or need to disclose at that particular time or in that particular moment. Also, as a counselor, we collaborate alongside our clients. They co create the meaningful goals in the strategy. We help them to see it from a clinical lens to kind of help serve their treatment plan. And then we always advocate for the needs of the clients. We are their champions and we help coordinate with other providers and their support system to help them meet their treatment goals. Now, the process of treatment planning, remember, you're going to gather the comprehensive client information. Remember the biopsychosocial, the mental status exam. Sometimes you may have to do a mini mental status exam depending on the clients and their needs. We also have to formulate a diagnosis. We cannot develop a treatment plan without a diagnosis. And that's also very important for documentation purposes, especially with insurance. And to support the diagnosis, you're going to need assessment data. So if an individual is struggling with depression and they're saying, or they meet 5 out of the criteria in the DSM-5 for major depressive disorder, we have to give them the inventory of the Beck assessment or the PCQ-9 to help support our diagnosis. Then we need to create measurable objectives based on the client needs, some short term and some long term goals. Short term goals is what the client can do right now in order to feel better between here and the next session. Long term goals is what the client will master over time being in therapy. Then you have to create the plan. You have to document the time frame, the interventions that you all created together. Notice I said you all because you're not creating the treatment plan alone. You're creating it alongside what the client needs. And then you constantly have to review and assess progress and adjust as needed. And remember, if and when you change the treatment plan, always make sure you get informed consent. Now, to collaborate with the client on goals, it has to be some shared decision making. So you have to know their values, their preferences, and you have to actively listen to them. We have to attend to their needs and be in tune with what they're saying, validate their experiences without judgment. Sometimes a client may share something with you and you don't have to fill that space with words. Sometimes being silent or listening or giving them empathetic attunement. Then we also have to give them information about their options, their experiences. If a client is struggling with substance abuse, this is where we come in. This is where we provide them with psychoeducation to help them with the challenges that they are facing. And then we have to constantly integrate their feedback on adjusting or changing the plan to meet their needs. Now, when you set short term goals, like I mentioned earlier, you target the most presenting symptoms first, establish the clear metrics for progress, and you set an achievable time frame within 1 to 4 weeks or between this session to the next session. And you do a stepped approach where you're creating building blocks towards the larger overall arching goals within their treatment plan. Now, for long term goal setting, you have to help them have a clear vision so that they can see themselves at their desired end state. If that means to have less anxiety, or 30% less anxiety between now and 6 months from now. You have to address their underlying issues, target their negative thought thinking process or their core patterns, and focus on their overall functioning and help them to create substantial change, coping skills. So, if an individual is constantly afraid of spiders, for example, we can use exposure therapy to help them know how to cope when they're around a stimuli like that so they can build lasting change and build skills to help develop them to become better, to seek the 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 overall vision that they want. Because when clients come to therapy, sometimes, not always, they may not know what they need and how they can help themselves. So they're going to need some handholding, they're going to need some guidance. But that doesn't mean us as therapists, we just drag them and we just take them along for the ride without their autonomy, without their input. We need their participation. And for them to participate, we have to build a therapeutic alliance. They have to feel like they can trust us. We have to be consistently empathetic, consistently active listening. We have to create a space for them to share honestly their concerns and their feedback. And we have to set boundaries. You know, we have to clarify our roles and expectation for the client and for ourselves, because we're not miracle workers and we also cannot read minds. So they must know that up front. And then we have to celebrate their progress. We're their champions. So we have to help them build confidence to achieve momentum in meeting their progress goals. When you're helping a clients balance their short and long term goals, we have to help them with addressing their immediate distress. We have to help them develop coping strategies, recognize patterns and their underlying issue, and create lasting transformation. So, what can they do each time they feel like they're going to have a panic attack? This is where we teach them deep breathing, exercising, grounding techniques, things that of that sort. Remember, treatment plan is about creating a plan that's in line with their diagnosis and giving them the autonomy and supporting them throughout the process. Now, also, with treatment plan comes treatment progress. And for treatment progress, we have to realize some factors that may affect some clients. So some clients may not be apt to change, especially if you get clients that are, referred by the court for therapy, or they have cognitive limitations, or they have external stressors. For example, if someone is worrying about their finances, they are not apt to thinking about how they can overcome their depression if their finances are in a shamble. And this is where we come, not to support them financially, but to give them resources like, hey, you may want to check your community action agency in your community if you are struggling with paying the light bill, their electric bill, or the gas bill, for example. And then also, another barrier to treatment progress is a mismatch approach, or a therapist is experiencing countertransference and their client is triggering their clients, what they say or what they do, or their experiences is triggering something within the therapist, and you don't have the limitations to train. You don't have the training limitations to help your clients. And this is where we go back to ethics again. Because if you don't have training in trauma, you should help your client by referring them out or seeking training and supervision until you feel comfortable. Does that mean keep your client if you don't have experience in trauma? No. The ethical approach will be to refer them out to a professional that can potentially help them or be a better fit for them, or your approach may be different. For example, if you have a client struggling with anxiety, you cannot treat anxiety with MDR, that's for trauma. anxiety will be cognitive behavioral therapy. So, as clinicians, we need to be cognizant of, okay, what is their diagnosis? What is it that they need? And how can I better serve them? And then some of our clients have environmental factors. You will have some clients that can't come to your office for therapy. So we have to accommodate them and provide different modalities like telehealth for them to be able to be seen. Some of them may not have the resources. They may need, hey, do you do a sliding scale? I know I need therapy, but I cannot afford it. And some of them have unsupported systems. How many times, think about yourself growing up, if you dealt with an issue and your parents or the people around you weren't supportive? So think about it too as a clinician. What do or what can possibly affect your client from meeting progress within their treatment? And another thing that helps them over with their treatment will be the resistance and avoidance. So some clients are not apt to be in therapy, especially clients who know or may not know that they may need or can benefit from therapy. So we have to normalize their resistance. We have to say, I know this is difficult, this is completely normal, but assure you that therapy is, these are the positives of therapy, these are the negatives of therapy. And then you explain it to them in a way to make them understand. And you use motivational interviewing techniques to kind to create that dialogue to help them explore why they are resistant to therapy and their treatment plan. Adjust your approach. That's important. Certain diagnoses, you cannot use a one size fit approach. What you would do for a client that has histrionic personality disorder will be different for a client that have substance abuse disorder, unless if they co-occurring. And even if they are co-occurring, you have to match their interventions or modify their intervention based on their readiness. You have to meet the client where they are, and then you have to focus on the therapeutic relationship, especially within the treatment plan, because if you build trust and you are consistent, it helps them to feel validated, and that will give them positive mental health outcomes. And you need to always find strength in your clients. Look beyond their problems, help them to discover the resources, and help them reveal natural ways that they cope and resilient factors that they may have that they may not be privy to. For example, when you design activities that leverage their natural ability, you have a client who experienced depression, but they shared with you that they were a good writer in eighth grade. Leverage that skill. Allow them to use their talents in their healing process because it's cathartic. And then focus on building positive experiences. Amplify what works rather than just fixing their problems, and incorporate their family and their community for their community resources. Build the treatment around their existing support networks. And if you're going to include their family, make sure you have a what on file, a consent on file. Okay? That's very big. That goes back to ethics. If you watch my ethics video, we covered that. So you may want to go back and look at that so you can get a more in depth understanding on how we can support clients when we are integrating their support system. Now, counseling is a resource. And because counseling is a resource, you're going to have clients that come from different walks of life. And you have to factor in their how they see themselves in the world, their family structure, if they're the first child, the last child, or the only child, or if they're a stepmother, You have to know what's available in their community, how to help them, their socioeconomic status, their education, and their religion or spirituality. Because these, taking all of these into consideration, help them with coping and better treatment outcomes. And not only that, that leads us to finding the appropriate level of care for them. If you have a client who's a harm or danger to themselves, you need to know, does this client need inpatient versus outpatient, or do they need residential? And that's really important. That's part of the treatment plan. Go ahead and watch my last video where we talk about assessment. Um, We spoke specifically on intake assessment and diagnosis, and that was a big area that covered the appropriate levels of care. So, if you, I don't want to fill this video up with so much fluff. Go ahead and go look at the video on the intake and assessment and diagnosis, and we talk about the difference between outpatient, intensive outpatient, residential care, or even group care, because that is important. Again, it relates the level of care that they need based on the diagnosis and what the client need at the moment. And remember, the most restrictive care is what? If you said inpatient, that was correct. The least the least restrictive care is what? You said outpatient, that was correct. Now, some clients may need psychiatric referrals. We are in no place to talk about or to make a suggestion about medication. We learn about medication, but we learn about it on a surface level in our graduate school courses. But we're not to say, hey, you have anxiety, go take a Prozac. No, we are to say, okay, if your anxiety are becoming, overbearing, would you like for me to give you a referral to see a psychiatrist? Or is there a psychiatrist are you seeing? We can collaborate together to coordinate the care so they can help, so they can see that they are making therapy in progress. So we explain the rationale, we address their concerns about medication, but we do not give them or tell them what medication to take. Now, some clients may need residential treatment referrals, and that's only if they are a safety concern or their symptoms are severe or outpatient has not helped them. Again, it's based on the diagnosis. Residential referral will be for someone that has eating disorder, for example, or a substance use disorder. Again, go back and watch my previous video if you want more details. And then we have to look at the planning services, how they're going to get continuing care, who's going to help support them when everything, said and done and they finish their treatment, and what strategies are going to be in place to help them from relapse. For us to have effective communication with these referral agencies, whether it's residential, inpatient, outpatient, we have to have effective communication. We need to compile relevant clinical information, establish the professional relationship via personal contact, give the proper release form, that consent form we discussed, and we have to follow up to maintain ongoing communication to help the client. And we have to make updates and adjustments in their treatment plan regularly, evaluate their progress towards their goals, listen to their feedback on what's working, what's not working, and modify approaches based on any assessments or findings. And then you have to implement the plan, and you have to put the revised plan into action. Don't forget to document the plans. Part of the treatment plan is documentation. use your SOAP notes. They have to be objective and structured. They can't use judgmental language. Again, the previous video, a lot of the content on the mental health counseling exam, they overlap. Ethics overlap with intake and assessment, which overlaps with treatment planning. Even though it's 15%, intake and assessment is 30%. Ethics is 15%. So everything overlaps. And because there's an overlapping, it's essential to learn what is it that the test is looking for. And once you know how to answer those questions and you are aware of what they're asking, then you'll be more apt to say, okay, I need to always choose the question that shows that I am working with the client, not against the client, and that I am acting ethically and legally. Just like I mentioned, ethical considerations, confidentiality, informed consent, boundaries, cultural competence, which is important. Some clinicians tend to overlook that. Please don't overlook that, because this is what you need to be an effective clinician and develop effective treatment plans, is to try to respect and to understand their diverse backgrounds. You're going to have clients from all different walks of life. Now, using treatment plan as a clinical tool helps to create a record of agreed upon work. They provide evidence of professional service delivery, helps you to track their progress, guide their decision making process, and it's a clear communication tool that ensures coordination and ensures continuity of care across team members. Now, the best practices is involve their family or their support person or other providers when appropriate, when you have client consent. You have to customize every treatment plan specific to the needs of the client rather than using generic templates. What I mentioned before, what you use for somebody that has bipolar disorder may be different than what you use for someone that's experiencing a trauma related stress disorder. And then schedule systematic plan reviews to ensure the relevance to the client's current needs and their status. And effective plans translate theory into practice. Those are what guide the selection of specific evidence based interventions that match the needs of our clients. Now, remember, you have to use motivational interviewing techniques. Start with small, achievable goals to build confidence within the clients, adapt approaches for cultural relevance, consult with cultural experts when needed. Supervision is not for just when you are an intern, supervision is also for when you are a practicing clinician. And develop something that has a time frame. Focus on key elements that drive treatment plans and create contingency plans or crisis management plan to address the needs or their safety needs before continuing regular treatment. So, mental health is becoming digital, and there are going to be a lot of questions that ask you about how you would respond with the use of digital tools that are now at our disposal. So we have to not only be culture responsive, know which client will benefit from telehealth services or come in. We have to use an integrative approach. Remember, it's not a one size fit all approach. And we can also use technology for them to do a what's the word I'm looking for? A Beck depression inventory test, for example, and the digital tools that they may need in order to share psychoeducational resources for your client. And like I mentioned before, those digital assessment tools, they give them immediate scores, they track their symptoms, and they helps the client see their progress. They have mobile applications that monitor their moods, if their symptom change, and they provide resources for practicing, skills in a real world setting and telehealth platforms. Remember, if you're going to use a telehealth platform, it also needs to be HIPAA compliant, HIPAA based, and you also have to share via intake, the limitations of technology. Go ahead and go watch that previous video, and intake and assessments and ethics, because I also discussed that. And then in conclusion, we have to realize that client success depends on how well their treatment plan is laid out. You have to use the results to help them make their decision, and you have to explain what it means and how they relate to the plan of treatment. And don't be afraid to revise the treatment plan if something isn't working, but always include the client in the process. Engage them in the progress reviews. Meet regularly to check their progress to see how far that they have come, because remember, this is collaborative. And with consent, speaking of collaboration, with consent, you can update their doctors, their PCPs, or their family, their teachers. You have to make sure, or it's for you to make sure that everyone is on the same page to help the client succeed. And the goal is to teach clients how to keep using the skills that they learned in therapy in their everyday life. Explain to them why it matters to stick to the treatment plan. It helps them to feel better and to reach their goals. I didn't add these slides, but if you listen, this is a bonus. Let's talk about if you have a client, right? They have general anxiety disorder, and they have worry and tension. To create an effective a treatment plan, let's think about the short-term goal. What would you think a short-term goal would be? Okay. So now, if you said something like use deep breathing techniques daily, you're you're in line. Now, a long-term goal will be what? To reduce their symptoms by 50% in 6 months. And in that same plan, you can include cognitive behavior therapy and relaxation. And you can talk about in that treatment plan the strength of the client. Are they motivated, or their barriers if they have a low tolerance for uncertainty? Our next case is a client presents with depression. A short term goal would be do one fun activity daily. Long term would be to improve their mood over the next three to 6 months. And the barrier to their treatment can be low motivation. Remember, when someone is depressed, they don't really have low motivation, but a strength could be their support system. And the interventions that you can use would be cognitive behavioral therapy or behavioral activation. Now, let's talk about a client who have PTSD, which will be different from a client that has depression or general anxiety. So the client with PTSD presents with flashbacks and have nightmares. A short-term goal would be use grounding techniques three times a week, at least 3 times a week. A long-term goal will be reduce their trauma symptoms in 6 to 12 months. And their barriers will be something like avoidance. Remember, people who have clients who have trauma may have avoidance and mistrust, and that is a barrier. And their strength will be their desire to heal and to overcome that trauma. Thank you for sticking around. I hope this was helpful. If it was, please like, subscribe, leave a comment. You can also message me at withstudentsinmind@gmail.com. You can follow me on all my social Catharsis, or NCMHCE Bible Prep. And if you're looking for the flashcards for treatment planning or ethics or anything else, click the link in the description to my Gumroad. You can download that. And I will also include, I haven't got it ready yet, digital flashcards that are going to be available via Anki, and I will share with you how to access those. Happy studying, and remember, you are built for this. Just stay the course.